Thumbs are up. Good evening, everybody, and welcome to this event at the Royal College of Nursing. I'm Diane Yarwood. I'm currently the chair of the History of Nursing Forum, and I've been one of the leads of this project that you're going to be hearing about this evening. Just need to do some domestic issues. There are no fire alarms planned, so if the fire alarm goes off, it is serious, it is real. Doors behind you, doors to the left of you, and follow the staff. And the assembly point is outside in the square. Yep, I think that's it. If you need toilets, through the back door on the left or through the doors on your left, down the stairs. There's also a cloakroom down there if anybody needs to leave things, but it's a bit late to do that now. First of all, I'm delighted to welcome my participants. What's really nice is they didn't take a lot of persuasion, because this is something that is dear really to everybody's hearts. Danny Kelly here is going to be chairing, and I'll be picking up at the end with the sort of Q&As. So it's lots of information from 6 people, 10 minutes a time. 3, 4, 5, 6, yes? Or 5. Sorry, can't count now. So I'm just going to hand over to Danny, and we will start. Thank you.
Thank you very much, Diane, and a very warm welcome to the Royal College of Nursing. It's great to be part of this event, which I think is really very important. I'm a recently retired former RCN professor at Cardiff University and currently convener of the RCN Fellows. Thank you for joining us here in person tonight, and for people online or who might be listening to a recording, I hope you also find a warm welcome and you find this evening interesting. World AIDS Day will be held on Monday, the 1st of December. It's an annual point, as we know, in the calendar that encourages a focus on those living with AIDS, HIV. The need for prevention and early detection to be available for all, and especially to ensure that effective treatments are available, are essential today. This includes protective post-exposure from agents that are now available, and even the possibility of vaccination now becoming a reality on the horizon. And what a different landscape it now is compared to when I worked in the field. I was thinking it's almost 40 years ago that I worked in Edinburgh. And if you remember, Edinburgh had a huge issue there with drug use and huge social problems at that time. It was a period of my career where I really felt compelled to help, and I know many of the people in this room felt the same. And we lost so many people at that time, and we remember the names and we remember their impact that they made. And it's important that we remember. And gradually science found some solutions, and we've got something positive to offer, much more so than when I worked in that field. The image on the screen is Jane Bruton. Where are you, Jane? Speaking to you earlier. Jane was the lead nurse on Broderick Ward at the Middlesex Hospital, and where people like Princess Diana and Barbara Bush were famously photographed going there to meet patients, shake hands, and try and break some of the taboo and the stigma that was so powerful and so destructive at that time. And others have written about that stigma, and we're going to hear tonight about some of the issues that have arisen from this project. People like Susan Sontag, I'm sure you're aware of, at the time, was writing about the guilt, the sense of punishment, pollution, or even invasion, those words that were used to characterize what was essentially human suffering. And as times change and as times move on, we remember the words such as plague, scourge, and punishment, moral punishment, etc. But tonight's event explores some of the issues around past times, but its message really is about today. And I'm sure that you will have comments and questions from tonight's participants. And I would ask you please to feel welcome to ask those questions and share your views at the end when Diane will take over the microphone to facilitate that period of discussion. Our speakers bring unique insights, and I'm delighted to introduce them to you. We've got a lot to cover, and the people bring their own views, and I will let them speak for themselves. But I'm just going to give a brief introduction to our first speaker, Paul Coleman. Paul is a BAFTA-nominated TV director and producer, himself having lived through and survived the AIDS pandemics of the 80s and 90s. He was inspired by the incredible testimony of those who have taken the same journey and the stories of those who were lost. As co-founder of the NHST, he is incredibly grateful to all those people who supported the charity and who have joined him in ensuring the testimony and the history of those times can and will never be forgotten. So, Paul, over to you. You're very welcome. Thank you.
Good evening, everyone. First of all, I'd just like to say thank you to the Royal College of Nursing for putting on this fantastic event. We, the NHST and HIV Story, have been working closely with them over the last year, and we look to increasing that collaboration over the next couple of years. I'll be showing you a film in a short while. It's only about 6 minutes long, but it condenses down what the NHST, the original charity, does, and also what HIV Story does, and much more succinctly than I can do. So I'll just give you a brief sort of overview of how this all started. As was mentioned, I've been living with HIV for over 30 years now, and was pretty quiet about it, to be honest. It's even in recent years, it's not always an easy thing in all circles to talk about. And I'd remained very quiet about it, along with a lot of people I knew who were HIV positive, didn't want to speak about it, didn't want to reveal too much for fear of stigma, backlash, problems at work and so forth. And some of those problems still exist today, unfortunately. But anyhow, as a producer, it was in my blood, in my DNA, to want to make a film about what had happened. And the reason that I wanted to make that film was because I had a very, very simple thought, and that was I was remembering a friend of mine whom I was very close to who had died of AIDS, and wanting to recount the times that I spent with him. They were very precious times, and I thought, who can I talk to about that? Just so we can go down memory lane and sort of talk about Paul. And I suddenly thought, actually, all the people that I knew that knew Paul were also dead. And I thought, what a terrible quandary to be in. And there must be other people like that, people who want to tell their stories, talk about their loved ones, their friends, their husbands or wives, talk about their lives and celebrate them in some way. And so I decided that was the reason why I would make a film. So 11 years ago, or coming up to 11 years ago, I started filming just with a couple of friends, with equipment that we had and with no money at all. Started to do some interviews to put into this film. And it was after the second interview, I suddenly realized we can't just make a film. These stories are so rich. They're so full of love and compassion and care. They charted, the LGBT community, how that was evolving. It charted so many things, so many rich streams of storytelling in each of these interviews. And so, randomly, I guess, I came up with the idea of let's do 100 interviews. And we went on to do those, initially without any support other than private donations from people within the LGBT community. As is ever the case with things like these grassroots projects, they are often the first people to step forward when it comes to things about AIDS. And so they supported us in those early years, and subsequently we've had lots of other private donations, especially from the David Foundation, David Lyon Foundation. So having got 100 of these films together, 180 hours worth of film material, and that was great because what we were doing there was preserving these stories. The reason we did those stories was because people were beginning to forget. 10 years ago, there wasn't actually, we're talking about it a bit more in the last 10 years. 10 years ago, there was hardly anything being said about HIV and AIDS. So we didn't want to lose them. We wanted to preserve them. And so at the London Archives, there they are for anyone to use, the public to use. You can be a researcher, you can be writing your PhD, you can be an author, you can be a playwright. We've had all those types of people go through, diving into this very rich testimony that's available. But we didn't want it just to sit there. We wanted to use it as outreach to people. We want people to know about the story of HIV and AIDS that wouldn't necessarily come across it or be interested in it. We want ordinary people to know about these fantastic people, living and dead, and what they did and the extraordinary stories that they have to tell. And so we came up with the idea of HIVstory, which is our big outreach program running for the next 3 years, traveling up and down the country. And in that way, we're engaging local communities, either through teaching institutions or through libraries, and in many other places. Anybody who would like to use our exhibition, which is out in the cafeteria there, anybody who wants to use it, please get in touch and we'll tell you how to do it. About 3 years ago, I think, I was giving a talk at the London Archives. This is to put things in perspective. I was giving a talk and I was talking about the history of HIV and AIDS and what had happened. And afterwards, a young woman came up to me, and she was studying for a PhD, and she said to me, "My goodness, Paul, that was fantastic." And I blushed red, thinking, God, I'm good. And she said, "No, really, it was just amazing." And I said, "Well, I mean, it wasn't that good, but why are you saying that?" And she said, "I've been studying this for some time, and I thought everyone who got AIDS was dead." And that was the understanding, and that's an understanding of a lot of people, and we want to disabuse them of that. So we want to go on telling our stories. We want our stories to roam the country. We want to create environments and groups of people who look into archiving, making their own collections, and celebrate the collection that we've got. So to put all that together and to tell you a little bit more, we'll now just run this short film. It will give you some more information. Thank you very much. Play the film.
We are the National HIV Story Trust. We exist to preserve the history of those affected by the AIDS pandemic of the 80s and 90s. We've produced films, books, audiobooks, podcasts, theatre, education, music, and recorded over 100 interviews. Men, women, trans, gay, straight, any ethnicity.
No one person's experience is going to represent the whole thing. It can't. But having a great many personal experiences, I think, will help future generations properly understand better what happened and why it continues to matter.
And now, the National HIV Story Trust are taking these stories out across the UK, raising further awareness and generating positive social change. By retelling these stories, we enrich and inform all generations about this important part of our culture. This is the HIV Story Project. HIVstory is a first-of-its-kind 3-year UK-wide outreach programme, which through a combination of live and virtual events will give people of all ages access to an often overlooked part of the UK's heritage. It will invite discussion and allow everyone to learn about the current issues surrounding HIV. We'll be offering skills training to local communities and opportunities for young people to start an apprenticeship in the heritage sector. And we'll be ensuring this important part of social history can never be forgotten.
I was looking after a young man, I think he was early 20s, and I said to him, "Is there anything that you want to do before you die?" And he said, "Yeah, I want to go back on a motorbike." And I said, "Okay, I can make that happen." I was a biker at the time. So I had a friend who was also working in the hospital who was a biker, and she brought her bike lid up, and Jane and I think a porter lifted Stephen onto the back of my bike because he was so sick. He had pyjamas on, he had the helmet on, and he had the syringe driver in his pyjama pocket, and he was really weak. So I just said to him, "Hold on tight, just hold on, don't let go."
So the whole thing about living wills that are now called patient directives, that came from HIV. You know, that was that they didn't exist before. So it was pushed for that you should be able to talk with your doctor when you go into clinic about what do you want to happen in the event of you becoming unwell. And of course they were accepted in the end by the BMA, which is a huge victory by activists to get that. And they were just made a huge amount of sense that enabled us to discuss about how we care for somebody. What care do they really want?
When I got made redundant from the Lighthouse, I then went to Chelsea and Westminster to work in the HIV team as the mental health specialist nurse in the HIV team. And I'm now a patient at Chelsea and Westminster. And I was there on Friday, and I bumped into 3 people that I looked after in the Lighthouse in the 90s that we were joking on Friday, saying they're going to outlive me.
When I was working as a nurse on the ward, if we were going in, we almost had to have barrier nursing, gloves, masks and all the rest of it, tralala, aprons, which seemed very over the top, unless you were on a cancer ward and someone was in sort of their sort of sterile units. But people were allowed to come and visit him without all of that. So I thought, I don't get it, and I didn't like it. Why? You know, it's either everyone wears it or no one wears it. But what I used to do is when I was going out onto the town and meeting up with my friends, I used to get all dressed up and then used to go in to visit him before I went out.
We had 12 beds. Each bed was 12 days of Christmas. We decorated all the beds and cooked our own turkey at Christmas. And yeah, it was a very nice atmosphere, social as well. And we had the fun run that I was saying in Battersea Park to raise money for the ward.
A lovely young man. He was in his early 20s. He was diagnosed HIV positive, went straight onto medication. I was just seeing him for routine bloods and, you know, sorting out his next prescription, and I was checking in with him, how you doing? He said, "Oh, it's great, so-and-so's brilliant, we're doing this, we're going on holiday." I was thinking, wow, okay, brilliant, fantastic. And he said, "Come on, can I ask you a question?" I said, "Of course you can. What's it?" He said, "Did people used to die of this?" I was like, yeah, pretty much everyone died. No. I said, yeah, everyone died. He said, oh my God, this is, he said, "I need to find out about this." And I said, yeah, you do. So it was, on one hand, it was wonderful that it was such a distant memory and those days are gone, but oh my God, we can't forget them. We can't forget those days. You know, we just can't forget all those people that died. That would be the crime, is to forget those people.
Real people, real lives, real stories of the AIDS pandemic.
Thank you very much, Paul. That's we'll come back, I'm sure, to the content and the message there. Moving on to Peter. Peter McCarrath is an honorary lecturer researcher at the Christie NHS Foundation Trust, where he previously worked as a clinical lead nurse for health and well-being. He also volunteers at the Moya Cole Hospice in South Manchester, providing therapies to patients and carers. In the 80s and early 90s, Peter worked in intensive care nursing here in London and was involved in caring for people affected by AIDS and HIV. Thank you, Peter.
Thank you. So I'm part of a team of nurse interviewers that are spread around the country. And we've had this wonderful opportunity to meet fellow nurses and to share experiences. And I've got another slide there with just that's it, wonderful. And we devised a series of questions and, and obviously tested them out with our interviewees. And we've sort of gathered and recruited people into this project. And it's been an interesting process because I think as someone who does interviews, and someone who's done this sort of work in terms of working with people affected by HIV and AIDS, what I found is listening to people's stories, more stories were bubbling up in myself. So I almost feel like I need to do another interview. One approach I take when I interview people is to use sensory language. I work in dementia care, I work with people at end of life, and people tell me their life stories. So I used cues in order to get people to tell me about what do they remember in terms of the image, the sounds, the touch, etc. And it's been a really rich experience. So, for example, the visual. We've talked about in intensive care wearing PPE, which we've all become familiar with COVID. But I remember as a charge nurse doing an agency night, and at the Middlesex, and the sister who knew me said, "Peter, would you look after the young man in the side room?" This was in the 80s. And he was ventilated with PCP, a very severe form of pneumonia. And because the other nurses didn't want to look after him. But she said, "You're going to have to gown up, and you're going to have to wear double gloves to take blood." So we had some very bizarre things going on at that time. But I remember that shift really vividly because nobody wanted to relieve me for that shift. They were very reluctant to be in the room, very reluctant to handle this patient. So there was a lot of stigma around this work. And I also remember when I was a nurse teacher, going into a bathroom with a patient who was very poorly, very unwell, only in his early 30s. And he'd been incontinent, and I was helping him to wash. And there was a student nurse wanting to come and help me. And he said to me, "Peter, do not let her in. I don't want her pity." And so, there were those sort of touching moments because his body was ravaged by the disease. He had Kaposi's sarcoma, and he actually died not long afterwards. Auditory. This story really struck me, and I was interviewing a chap in the Northwest who was an AIDS counsellor and coordinator, and it was 1987, and he was asked to go and speak to student nurses about his role. And he was introduced by the senior tutor as the pox doctor's assistant. You can imagine how he might have felt to be introduced to student nurses right at the beginning of their career. And he said to me, the stigma was highlighted by this. It was almost like treating it as a joke. And he felt very hurt for himself and for the people he cared for. And he didn't say anything. But once that person had left who had introduced him, he then engaged with the students about stigma and what have you. And he said now, subsequent to that, it was a big learning lesson because if anybody made anything like statements like that, he would stand up for himself and challenge it. So there were a lot of nurses in my interviews who were standing out of their role, who were stepping up. just a very quick one, kinesthetic. My friend David, who's here, was working in HIV, and he had a young man in clinic who was on some new medication, wasn't responding to terribly well. I have to get this story right. And he said in the chat to David in the counselling session, I'm going to book my place to go to Switzerland, to Dignitas. And as he was leaving, David was setting this scene, was about everybody was very touchy-feely, comforting. One of the nurses, who's very huggy, hugged him, and this chap said, well, I'm going to Switzerland. And she said, have a wonderful time. I believe Switzerland's a great place to go to. But it turned it around a bit because of her, her love and her attention. And he did come back to clinic and his counts did improve. So that was really, really good. Just the last one was a story about a HIV counsellor in the Northwest again. But she had a young woman from Africa who was over doing some work. She was come over to this country to earn money, but the immigration people were after her and other people who were trying to earn money in this country. And she turned up at A&E very unwell, but came for testing, and she saw this young lady on a regular basis, and she used to come for breakfast before she went to do what work she could do. And so they'd have sharing toast and jam, and she'd share her life with her. And this went on for a number of weeks. She sorted out medication for her. She tried to see if she could get her to stay in the country for treatment. One day she didn't turn up for her jam and toast, so she went looking for her, went to her house of multiple occupancy. She wasn't answering the door. A neighbour shouted out and said, the immigration people have been and they've taken her. So, and she was really quite, she'd got very invested and very supportive about this person. So it's really interesting how asking questions and getting people to unpack, because this is some time ago for some of the people that I interviewed. 8 out of 10 of the people had retired. And so actually this stuff bubbling up. And we did an interview today with Annette, who's going to join me. And we were bubbling up all the time with stories coming from sharing. So thank you so much for listening to me. And I'll hand over to Annette, if that's fair. Good.
Peter, just before you leave the lectern, do you want to say something about the
smelly sticks?
Yes.
Just to say that the smells can be another thing. So people remember the smells of wounds, the malodor, the breath, etc. But also positive smells. So I was working with a patient who loved frankincense. And when I was working, we were providing massage and aromatherapy oils. And he was dying, and we had frankincense in the room, and his friends, his family said, what a gorgeous smell, because he was very spiritual. And so memory is linked to smell. So have a little sniff of some oils and see what memories come up for you. Thank you.
Thank you very much, Peter. Our next speaker, I'm delighted to welcome Annette Breen. Annette is a retired nurse and health visitor. Her first post after she qualified was at Charing Cross Hospital. Seems to have been a centre of activity at the time. And she remembers many young men with AIDS and HIV who were cared for there. Annette worked for over 40 years in the NHS and for associated arm's-length bodies in a wide range of roles through direct patient care, quality and safety, operational management, through to policy and strategy, both at regional and national level. So a huge amount of experience and insight. So thank you, Annette. We look forward to hearing from you.
Oh, hi. It's great to see you all. So I'm just going to give a few little sound bites of some of the interviews I did. So I did 9 interviews. So one of them was with a lady called Morvia, and she was a HIV and AIDS coordinator for Black and minority ethnic communities at the Health Shop in Nottingham. So the Health Shop in Nottingham was set up with some ring-fence funding related to the HIV/AIDS pandemic in the sort of late 80s. And so Morvia sort of was very keen to go and work there because she'd never heard of it till she went to work there. And the narrative at that time was that the only populations that were affected with AIDS were gay men and Africans who'd been eating monkey brains. So Morvia was very keen to dispel these myths. So the people who went to the health shop, they would be quite all age ranges. It was an anonymised building in Nottingham city centre. It's still there, still functioning. And people would go there for psychosocial support, needle exchange, condom exchange, and to use the resources. So it would be gay men, sex workers, and quite a lot of guys who were going to the gym using steroids. So one of the things Morvia was telling me, when she first started working there, she was really, really keen to learn. So she took home lots of resources that her co-workers had given her. So one of the resources that they'd given her, so this was back in the early 90s, they'd given her this video called Midnight Snacks. So she made tea, she made dinner for herself and her partner, and they sat down, and Morvia said, let's put this video on and watch it. So she was all sitting there very keenly, and then the video started, and there were two men in bed together. One got out of bed, he went downstairs to the fridge, bent over the fridge, naked. His partner came down, started rimming. Morvia's partner, he dropped his cutlery on the table, he leapt out of the chair and went and pulled the plug out of the wall so she couldn't watch the film anymore. So here's Morvia's ex-partner. So Morvia went on to talk about this sort of real stigma in the black population of being gay and, you know, people being affected with HIV. She talked about a guy who came in, black guy came in to see her, and he wanted to use the resource centre. And she said, okay. And he said, oh, can you come and show me where things are? So she went down because she said, oh, I think he's got something to tell me. So this guy, he said he needed to get something off his chest. And he'd been in jail for a short period of time. And while he was in jail, 2 male prison officers raped him. He couldn't tell anybody because of the stigma in his community, because he would have just been ostracised. I suppose it would be akin to a single woman in the 1920s saying she was pregnant, just ostracised from society. I'll talk a little bit now. So my colleagues, ex-colleagues, so Gail Beckett, who worked on Broderick Ward, some of you might know her at the outset, and Tracy Lamming. So they both went on to become health protection practitioners. So in the early noughties, they got some funding they were working for the Health Protection Agency, which went on, is now UK Health Security Agency. So Gail had been doing her, prep for her revalidation, like a good girl, and she'd read something about transport hubs being a centre for transmission of HIV and AIDS. So Tracy and Gail got some funding through the HPA, and they decided to set up a mobile testing site in Lincolnshire. So Lincolnshire, for those of you who don't know, it's on the east side of the country, very sparsely populated, very rural, and it's got a few market towns dotted about. So they set up their mobile testing site because a lot of lorry drivers transfer through there on their way from the ports on the east side of the country. And they had 2 outreach workers. So they set up this mobile van, the intersection of the A17 and the A15 in the middle of nowhere, because it was known this was a site where men would go and have sex with men in lay-bys, but they denied they were gay. So they set up this, and I said to Tracy, and they set it up, and it was in Tracy's husband's builder's van. So I said to Tracy, so the Health Protection Agency were happy for you two to go off in your husband's builder's van. And she said, yeah, but don't say that because I might get struck off. I said, I don't think so. The police would get very antsy about it. and they would write to the owners of vehicles. They would look up their registration number and write to say that the owner, who might not be the driver, who might not be the owner, had stopped at a site where men were known to have sex with other men. So they had to do a lot of work with the police. And I want to give a little shout out for women, actually, because women are quite often overlooked in the HIV and AIDS pandemic and how things have changed for women. So I spoke to Dr. Elizabeth Carlin, who's a consultant in sexual health medicine in Nottinghamshire. She's also chair of the British Association for Sexual Health and HIV, so a very influential woman. She qualified in 1984 and has worked largely in sexual health for her whole career. The thing that made her most proud, she said, well, there's quite a few things, but one of the things was how things have changed for women. So she's saying in the early days, women didn't really disclose if they had AIDS, HIV, they kept very quiet about it. One of the things she did say, if it had been a condition that affected primarily women, perhaps the progress in treatment might not have been so rapid. Gay men were a very politically active group, and they came together and united and put pressure on for things to develop. So going back to our women, so in the early days, women would choose probably not to have a baby because the risks of transmission were so high. You know, I think it's from breastfeeding 15%, can't remember what it is for a normal vaginal delivery. Sometime in the early 90s, it was decided that maybe testing women would be a good idea. So Elizabeth was part of the group that got that established nationally, but it was opt-in testing. So women were asked, do you want to have a test for HIV? Of course, they said, no, I'm not at risk. They were already being tested for syphilis, so during the 90s, and I was involved in the rollout of this, it got changed to opt-out testing. So it became part of just mainstream routine antenatal care. And the uptake went up from about 10% to it's about now 98, 99%. So that's good news. And then also during the time period, we've got the we've got the AZT coming on, the antiretrovirals. So now women can choose to have a baby, and their chance of transmission to the baby is less than 1%. And Elizabeth thinks it's wonderful because just recently, a woman affected with HIV came to see her with her adult child, grown up and healthy. So it's great to end on a good news story. And thank you for listening to me.
Thank you very much, Annette. There's so much in these brief recollections and presentations that at the time, I suppose if you were there, it was a time when nobody really knew what was round that corner. Were things going to get much, much worse? Were they getting better? And one of the things that people really needed, I think, if you were a health professional, was education. They needed information. They needed to know what to do and what was the best thing to do. And so we relied on people like our next speaker. And I'm really honoured to welcome Carol Pello. Dr. Carol Pello, if you were around at the time, you would have known her work, and with her colleague, Professor Robert Pratt, for over 20 years. Initially when HIV and AIDS first hit, setting up courses, setting up programs, and pushing and calling for more education. They both ran a unique AIDS education unit that covered all educational initiatives in the Northwest, Thames region here in London, and also abroad for the British Council and the World Health Organization. As if you know that time and you were around, you know that they wrote and they published and they provided people with some information, which is what we needed. So I'm very honoured, Carol. You're very welcome. Thank you.
Well, thank you for a very generous introduction. It was an interesting area to move into because up until the HIV epidemic, I've been working in pre-registration, and so it was all fairly mundane and nothing very interesting. But going to work in an HIV unit, it was like putting all the taboo subjects together, because we suddenly had to start talking to our students, whether they were students for pre-reg or post-reg, about all the taboo subjects like death, drugs, sex, sexuality, and it was really known as the sort of rock and roll era of teaching. And so what was useful for us is that we ended up teaching across a whole variety of subjects that had never been linked before. So we had to choose our group very carefully that felt comfortable with all these subjects, but also we had to link in with people who could teach on counselling, drug use, sexually transmitted infections, HIV testing, and whether you should or you shouldn't. And counselling and communication became a major part of our work. And I think that's really important, because on the first courses that we ran, we made our students do a reflection each night on how the course had gone for them. And the reason we did that was to get them to understand they needed to listen to patients' stories and understand where they were coming from. One of the most interesting ones, which I found a bit of a challenge to start with, was talking about safer sex. And I could have a whole group of 80 people, you know, in a room, and you had to suddenly start engaging them with how do you practice safer sex. And one of the things that we found the most interesting was in pairs getting people to tell one another about their most embarrassing encounter. It didn't have to be necessarily sexual, but the most embarrassing thing you've ever done. And people found that really, really difficult, which is understandable. And then somebody said, so how do you think children feel about talking about abuse? And how easy do we make it for them? Because if you can't tell somebody you hardly know about a really embarrassing moment, how can you expect children to be managing to say that too? One of the other options that we actually managed to do was working across lots of subjects was around hepatitis B. And safer drug use became one of the major parts of our teaching. And getting people immunised against hepatitis B was a major newish initiative, but had never been taken up very strongly. But once we could put it with Hep B and HIV, people then started to get, taking it up as being a good thing to do. And that had a knock-on effect for diabetic patients, which sounds bizarre, but it's true, because up until that time, patients with diabetes had a very restricted access to syringes and needles. And because of HIV and drug use, suddenly diabetic patients could have one needle for each time they wanted to inject themselves. You didn't have to keep it in a fridge necessarily, or whatever. So I think that was, we had lots of knock-on effects of how our education affected other areas of care. But there was also things that we had to learn around community care. Now, what's been mentioned already is how important community care was, because although in the early days people would be dead within 3 to 6 months of diagnosis, as they went on to treatment, of course, people lived longer. And we had all sorts of issues around community care, because people didn't want to be advertising that they needed special refuse collections if they had gross incontinence. No, we'd never asked that about other patients. We just assumed that was an okay thing to do. So we had to think about how do you make that a discreet and yet important part of life. There was also, we were very lucky, Robert and I travelled extensively running international courses, and I'd like to acknowledge Norman and Jean at the back, whom we met in Nigeria and have been great friends since then. It was very interesting teaching in India and Africa and Pakistan And you suddenly realised that things like flip chart paper, which we use like toilet paper almost, is you could see the teachers there were sort of shrinking every time we turned over a sheet of paper, because you suddenly realised that's an expensive item for them. So we always took as many things that we could do so that we could leave, like the videos and the books and everything. But suddenly realised that paper is not an easy thing to get hold of. And also people's stories of HIV abroad was also really instructive. We had one young lad on our first course in Nigeria who was dying of AIDS, and he'd been allowed on the course, and it was quite interesting to see a lot of the other nurses were not very keen to have him there until he told his story. And this lad had a dreadful mouth, he had bad diarrhea, he was losing weight, he wasn't eating properly. And I asked him just to keep a diary for 24 hours about what the symptoms were that he was suffering with and what was easier. And when I looked at his diary in the morning, I had to say to him, "What's this thing in the morning here?" And he said, "Oh, I was told I need to drink my early morning urine because that would cure me of AIDS." And you suddenly think, how could people treat somebody who is so sick on the understanding that drinking your early morning urine would be a good thing for you? We also did a lot of work with Her Majesty's Forces in Britain, and I would have to say they're one of the best groups ever to teach. Simply because if you asked them to get into groups of 3 or 5, they would do it instantly. There was no messing, you just got up and got on with it. Whereas our normal courses, you had to kind of encourage people to move and join in and help out. No problem with them, it was absolutely fine. But I want just to finish with a few things that will kind of reinforce what other people have said. And one of the lessons learned is that everyone is vulnerable. It's no longer a gay or a drug user's course, and that has an effect on the wards. Because when I went to first work at Mildmay, it was very much a gay area. And you suddenly think, how would women get on here unless you make appropriate changes? We also have to accept that you should never be surprised by what people tell you. My doctorate was on it was on antenatal HIV testing. And the first lot of interviews I did with women were all from Africa area. And the first person I interviewed, I said, "Now I want you just to tell me, how did you get pregnant? And then we'll take the story from there." And her opening line was, "I was multiply raped in prison. And that's where I picked up HIV." And you suddenly thought, "Oh, I don't think that's in my schedule, actually." How do you deal with that? Fortunately, all the women I interviewed knew they'd been asked to have an HIV test, so thank you, Annette, for that contribution. But they were very surprised, even this woman who'd been multiply raped, that she could have actually picked up HIV. And she had no idea who it was in prison, but she was multiply raped. So I think you never need to be surprised when you're doing interviews that people will tell you things you weren't expecting. A lot has been said about stigma tonight, and I would just like to say what we had to learn was to accept that carers are affected by the media. And unless you have good education, you can understand why they or their family don't want them to care for AIDS patients. Or they wanted everybody to know that who was HIV positive and who wasn't. And a lot of it was due to ignorance. And so we had to start by looking at courses that would help people to recognise what those issues were and how you got round it. We've talked a lot in the past about confidentiality and how important it was for people to keep their status private. But the problem has just been mentioned that a lot of women who are HIV positive end up having caesarean section. That's not an issue in the UK unless you're from Africa. And most of the African women, when caesarean section came to be the norm, said automatically, you must be HIV positive, because most African women would want to deliver vaginally. And you suddenly think, well, we'll have to work out how we get around that. We've also had a lot to do with dealing with who's the guilty and who are the innocent. And we had a lot of debate on our courses that, gay men were guilty, drug users were guilty, but people with haemophilia are innocent. And you suddenly think that throws up a whole range of what people are making judgments about people's behaviour. And I think that's a very interesting one when you ask who gave them haemophilia in the first place and who gave them that dose of factor VIII that gave them HIV. So there's a lot of interesting turmoils about who gave what and why. We've moved from acute care. As I say, I had a friend in my team who was diagnosed with AIDS just as multiple chemotherapy came in. And he didn't believe he was going to live very long. And he'd worked in the NHS and he cashed in his pensions because he expected to be dead within 6 months. And he's still alive and he's having to work because he'd spent all his pension money. He didn't realise that he'd still be there. So we've had to work with GPs who are not necessarily keen to do so. We've had to involve people in shared care, including use of informal carers. And I think out of all, I think the important thing was just mentioned, I think by Annette was said, the patient's choice is key. And that really struck me when I first started in HIV and AIDS, was working at the Mildmay clinic in the East End, is that patients could choose when they woke up. I said, excuse me, as the ward sister, I'm used to getting people up at 6 o'clock or beforehand so that we're ready, for the beginning of the day. No, that doesn't happen anymore. And so I think one of the key things that people made us realise is that patients have choices. And so, especially at Mildmay, they chose when they woke up and when they wanted to get going. And I wanted just to finish with one last thing, and that's about the language we use. And just to ask you, I'm sure a lot of you speak second languages, but if you are talking in your foreign language, would you know the difference between home office and home visit? And for a lot of women, that's a very dangerous thing, because when they hear home, they think of office, not a health visitor visiting them to look around their care. So I think language, whatever we use, should be thought through carefully and considered appropriately. Thank you.
Thank you very much, Carol. We really mustn't minimise the impact that had at the time when people were so unsure what was safe, what was necessary, and how to care for people. So thank you for all that you did then, and with Robert, Carol, thank you. Our final speaker, I'm delighted to welcome Professor Ben Thomas. Ben will be well known to many of you as a leader in mental health nursing. He's now helping at the RCN down in Wales as the Mental Health and Learning Disability Advisor there. And he's also Professor of Mental Health and Learning Disability at London South Bank University. I know Ben's research interests are very wide, but they include addressing health inequalities and improving the mental health of minority and disadvantaged groups. So you're very welcome. Thank you, Ben.
Thank you, Danny, and hello, everyone. Good to be here. And I'm going to be talking about what we've learned, really, from the voluntary sector, who were incredibly important during the HIV and AIDS pandemic. And without them, I think, as Carol said earlier, progress would have been much slower. But before I do that, I want to give a shout out for the Royal College of Nursing, because I think during this time they really rose to the challenge. When other disciplines was lagging behind, I think the Royal College of Nursing were out there really challenging, accepting, trying to improve things, trying to treat people as human beings and not, as all the things that we've heard today. And they put on one of the first training courses, the English National Board, as it was called then, 934 course. And I was very fortunate to do the Train the Trainers course at that time. So I'm going to start off in 1981, which was a very important year for me because it was when I left Wales to come and live in London. It was when I went to university. It was when I met my partner, and it was when we learnt about HIV and AIDS, primarily in this country. So that time was a very important year for me. I finished university in 1984, and I also did a training course for mental health at the time as well. And HIV was really taking off, and I wanted to do something useful and helpful for the community. And I discovered the Terence Higgins Trust. And now I'm sure you all know about the Terence Higgins Trust because it was one of the first HIV and AIDS charities to be set up at that time. And it was groundbreaking. It was a really groundbreaking charity in many ways. Its purpose at the time, I remember, was to raise funds for research and raise awareness, provide support for those affected by HIV and AIDS, challenge stigma and discrimination, and also promote safer sex practices. But for me, the reason I joined is because it had a new buddying scheme, and which I thought was absolutely fascinating and what I wanted to do. So I wanted to become a buddy so that I could go and look after somebody and support them during this period of when they had HIV and AIDS. However, by this time, the number of deaths were really mounting in this country, and it was becoming evident at the Terence Higgins Trust that we needed to support people, the partners of people who had died, and also family members and carers of people who died. And we didn't particularly have enough people to do all the counselling that was required, even though we had loads of volunteers. And so we came up with the idea of running a support group. So we piloted a support group. I was asked if I would do it because as part of my training, I'd undergone group analysis at the Institute of Group Analysis. And that was a very sort of psychotherapeutic model. And I didn't want to do that, but I did want to provide a support group, a place, I suppose, a space where people could feel safe, people would feel welcomed, people could be supported, people could be comforted, and people could learn from other people's experiences. And, and we operated it on a very, trusting people, respecting people, and we had some very simple ground rules. The group, I think, was a huge success. It went from strength to strength. We normally had about 10 to 15 people attend the sessions, but there were 5 guys who attended the whole 3 years that we ran the group. And they're probably still going to the Terence Higgins Trust, I expect. But they found it so supportive and comforting that they attended the whole time that I was there. The interesting thing was, the first couple of groups we had, it was all partners of gay men. And then all of a sudden, we started having parents along. And, it was really interesting because the parents had very different needs in a way. A lot of them, were ashamed that they'd had a child, and it was normally, at the time, it was normally a son who was gay and who got this horrible so-called plague and had died. So they wouldn't talk about it to their family. they would cover up and tell their family that their son had died through some awful accident or cancer or whatever it was. So there was a lot of shame and guilt experienced by those families. And they also, a lot of them, felt that they hadn't done the best they could by their child. So they sort of, some had even thrown their children out. As soon as they'd come out to the parents, they'd been asked to leave their house or leave their home. So it was like, and then when your child has died, you're left with that, and you're left with that guilt. So there was a lot of working through, what if I'd have done this? What if I'd have done that? Could I have done something better? So I learnt a lot from the Terence Higgins Trust, and I think the whole voluntary sector has moved forward because of the HIV and AIDS pandemic and the way it dealt with that. So I just want to run through a few things of what I see or what I think has happened to charities in this country. And I mean, God knows we need the charities that we've got in this country at the moment. But one of the things I think was that there was a shift with the Terence Higgins Trust and other charities, a shift from a sort of crisis response to a long-term advocacy response. So early on, the AIDS charities were born out of necessity, basically. The government action really lagged behind. And I was, at the time, I was part of ACT UP and, Silence Equals Death, all those lobbying groups that were trying to get the government engaged and to take action. But for me, the Terence Higgins Trust, I mentioned the buddy in service, they led and were pioneers in peer-led support. So it was like being in a situation where you were vulnerable, but being helped with somebody who was a peer for you. And now in mental health services, peer support is everywhere. All mental health services provide peer support services, and they're brilliant, and I've seen them in action. But that stemmed from way back then. They also provided community education. The safer sex practices was something that had never been seen in this country. And as Carol said, you really had to address these sort of issues that we'd never really talked about. They also were very onto a rights-based advocacy setting. And I think, that has been a template, really, for other charities that have taken over. The other thing I learned was that they truly operated an integrated health and social care work. So these charities demonstrated that health outcomes depend on also addressing housing problems, on addressing mental health issues, on addressing poverty and stigma. You just don't look at the health outcomes, but you have to look at the person holistically. And still, these days, I hear that as care professionals, we're still not very good at doing that. But charities were doing it way back then, which I thought was fantastic. Of course, some time moves on, and the other thing, I guess, was the professionalism and the actual way that they influence policy. So organisations like National AIDS, the National AIDS Trust, moved beyond service delivery to policy lobbying, shaping laws such as anti-discrimination protection under the Equality Act. So they were real, they learned how to lobby. And I know the RCN does a lot of lobbying, and I think we're pretty good at it. But, they were small organisations to start with, but they knew how to lobby, and they made the best of that. And now, of course, we've got other new charities since the 90s. So we've got the Elton John AIDS Foundation, which introduced social impact bonds. I don't want to go into them too much, but they've basically for HIV testing. And what they've done is they've actually saved the NHS millions, because it encourages people to have HIV testing, so you actually, get diagnosed earlier, and then you can put all the preventative stuff in. And that's become a model for other health interventions. They've also, I think, done global advocacy and partnership. So organisations like Stop AIDS and Frontline AIDS are linked. They linked UK activism to global health agendas, influencing international funding. And then finally, I think what they did, and the thing that stood out for me, was normalisation and anti-stigma campaigns. So these charities, you know, while we were having the government campaigns of the tombstones and, you know, frightening the lives out of people, these charities helped, I think, transform HIV from a very highly stigmatized condition into a manageable chronic illness, reducing stigma and discrimination and promoting equality. So those are the things I think that we've learned from the HIV and AIDS charities at the time, and I'm really proud that I was part of that. Thank you all very much.
Thank you very much, Ben. I think it is a lesson in how people took control, actually, and fought back literally to receive what they needed from the government eventually. But as we're in the Royal College of Nursing, before I pass over to time for questions, I just want to mention Richard Wells, and some of you hopefully would know that name. Richard was for many years the lead person here in the college for AIDS, and was a remarkable person, and, you know, carried the flag through very difficult times. Personally, he himself died of AIDS, was very open about it, and talked even when he was in the advanced stages of illness. So I was very privileged to know Richard, and I wrote his biography recently for the Oxford Dictionary. So I think we mustn't not mention Richard Wells tonight being here in the Royal College of Nursing. So I will thank all the speakers and pass over to Diane, who is looking forward to your comments and questions. And I believe we've got a microphone available for us. So thank you very much.